Good afternoon, everybody. Let me welcome you to second CRTM lecture of this year. So once a month, we are regularly having lectures on different topics related to tropical medicine under CRTM. Today's the speaker is Professor Kosala Weerakoon from Rajarat University. And first of all, let me thank Kosala for accepting our invitation and coming all the way from Rajarata, Anuradhapura, to Peradeniya. I'm sure is coming home because Kosala is a graduate from this faculty many years ago. So I'm very much thankful to Kosala for accepting the invitation and coming. To say a few words about Kosala, Professor Kosala Weerakoon is a professor in parasitology at Rajarat University. And he's one of the eminent researchers in Sri Lanka and has done a lot of publications related to infections and the parasitology field. A few words about my relationship with Kosala. Kosala was working with me as my pre-intern many years ago. So very hard working pre-intern during that time. So there was a mismatch of supply and demand. So I could not actually supply enough work to Kosala because his demand was so high. So that was the nature of Kosala. He was going all over from here to Kurunangal, everywhere to collect data. Even I was very active during that time. And after that, Kosala did his internship here, then joined Rajarat University, then proceeded to Australia for his PhD and came back. So that's a few things about Kosala, right? So once again, thank you, Kosala, for coming. Over to you. Yeah. Yeah, that's okay. Yeah,
Thank you very much, sir, for that kind introduction. And it was a great time, actually. And then you are true, sir. Like, you know, it's genuinely the home for me. And before starting the talk itself, I would like to dedicate this talk as a tribute to late Professor Donald P. McManus, my mentor and supervisor in Australia. So, like Ulranda said, like when I was in Australia, like all the support, guidance, and even after coming to Sri Lanka, his helping hand was a great support and courage for us to proceed with. And I take this time to remember him. And yeah. Right. So rather than in-depth technical descriptions or evaluations, today I'll be focusing on a much broader scale towards concepts on certain trending avenues of diagnostics in medical practice. So I'll be more focused towards preventive perspectives, which anyway will be applicable for treatment and subsequent management options as well. Right. Yeah, coming into tropical infectious diseases, the topic I chose. These are diverse group of for anyone who's getting into the field or relatively budding to the field in the audience. Diverse group of communicable diseases that prevail in tropical and subtropical regions across the globe, and spanning around over 150 countries actually. And of these tropical infections, we have these WHO declared neglected tropical diseases to show the influence or the significance, the global significance of tropical diseases. I will just take these neglected tropical diseases and its impact just as a portion of the entire tropical infectious disease arena. You can see the figures, not the most updated, but still we see like over 1 billion people across the globe affected, and 500,000 people succumb to the NTDs, and close to 150 countries we see these things. And actually effective control is mandatory for all these things, so that we know the problem related to these tropical infectious diseases and neglected tropical diseases, and effective control is the way out. I mean, that's what I said like at the beginning as well. I would focus more on prevention and control and the role of modern diagnostics towards prevention and control rather than direct hospital-based patient care related diagnostics. Anyway, those are going to be applicable for that one as well. But interventions are guided basically by the local epidemiology and available appropriate measures to detect, prevent, and control diseases. So these are, I'm just showing you some global attempts to control these things. So the core of these things, or all these programs would be to see the actual picture, the situation of these diseases in communities, in different regions, different countries, and across the globe. The way out is to have good diagnostics in place. Just an example, the recent roadmap by WHO for neglected tropical diseases for the current decade, 2021 to 2030. So they ending neglect to attain the Sustainable Development Goals. These are some targets. When you look at that, seems a bit ambitious. Looking at the previous roadmap and WHO targets, how much they achieved over the last decade, and then this definitely is relatively ambitious, but still we need to appreciate the targets and then proceed and work towards that as nations, part of the nations from the globe. I mean, 90% reduction in people requiring intervention against neglected tropical disease. So this is a huge target, and again 75% reduction in disability-adjusted life years affected neglected tropical diseases, and getting the number of countries down to 100 having neglected tropical diseases, and at least to eliminate 2 neglected tropical diseases to eradicate from across the globe. Though I said that these are ambitious and high targets, thinking of the nature of how the knowledge is doubling. In 1950, we saw knowledge doubling, taking about 50 years for doubling knowledge, and then towards 2000, we knew it's happening about 5 years, and now it's about just 70 days. So with that, and then that's just a slight indicator of what's happening in terms of advancement of knowledge means science as well, so that this though at this stage I say these are ambitious, it might not be the case towards the end. Yeah, so these are some of the target diseases in that guideline. And implementation of appropriate measures with high coverage for these programs, contribute to achieve the targets of these WHO aims on entities towards elimination of many and the eradication of at least some within this next decade, as we discussed. For us to, as I've depicted here, for us to reach these goals, it's and to eliminate tropical infections, it's very, very important that we have improved diagnostics in place. That's the baseline. I'll touch on, I'm coming to that a little later after taking you through. So, when you look at where we are, where we started things, initial, in terms of diagnostics, actually, initially, physicians relied on 5 senses to diagnose diseases. Clinical understanding, direct clinical understanding, and then these are famous urine chart in my left side in the screen. You see, those days urine was as of the existing records, urine was the sample specimen that told a lot about patients. They used to smell it, they used to see the color and texture, and also they used to taste it to come up with, especially non-communicable diseases, and obviously diabetes. They smell, fruity taste. That's well described by those physicians over there. So that is how these diagnostics concepts and approaches came in, and then progress to basic conventional diagnostics, and then that's the early stages. You can see in my right hand side, this is from Science Museum UK. These swab kits used to diagnose diphtheria. So I mean, these things were gradually advancing, and now today we are in towards, like, starting from basic diagnostics, conventional diagnostic like microscopy, then to imaging, and progressing from that, and then coming into automation and data analytics, subtyping, and specific detection for a possible tailor-made, customized care for specific patients. Hello, and yeah, so as I was telling, we're talking about tropical infectious diseases, and precise diagnostics are pivotal in identifying pathogen species and strain detection. As I said, back then, this was not a big deal. Syndromic approach could be the aim, or just a matter of relieving the patient who is pregnant, as we've read and understood in some of Hippocrates, do no harm, alleviate the pain. So that's the kind of initial approach. But now it's more towards specific detection, eliminating the disease from the entire disease from the patient, and as well as trying to prevent and control all the diseases. So pathogen species and strain identification is the key. So precise diagnostics is the key here. And once you know the pathogen species and strain identification precisely, specific treatments can be given to the patient so that the prevention of complications and drug resistance can be avoided, and that provides this patient care. At the same time, specific vector or reservoir identification, and then environmental detection as well. And then, of course, vector control is just an example here. I'm referring to all other measures that you would take with these diagnostics, help of this diagnosis. So that helps even the patient, direct patient care, and these ones helps disease control and elimination. So that is the ultimatum, but then precise diagnostics is the root or the core of all these things. So when we think of these traditional or ongoing infections or emerging or re-emerging infectious diseases, the best controlling strategy is to hold their spread at an early stage. So that is the, as we know of the common norms as well, this is exactly what we need to focus on in the modern world. And so it needs early diagnosis of disease by rapid and reliable detection of disease-causing agents. Yeah, just looking at the basics of diagnostics, convenient specimen collection is the most important. Let's go down and then see. We go for the most accurate and the best diagnostic technology available, and then we, in retrospect, we try to think of, okay, like we have the state-of-the-art best diagnostic available, and then of course, if that is something that actually we cannot utilize, and even as simple as a circumstance where you cannot apply this using the specific sample that you want cannot be collected from the target population, it's not going to be of any use. So that's why I'm starting with that. Convenient specimen collection is something very, very important. And then when we are targeting the best diagnostic technologies, it's very important that we think about the starting point, the convenient specimen collection, and then appropriate biological material, of course, the subsequent processing, DNA, proteins, RNA, metabolites, everything. So those are the ones actually being tested in the modern day molecular diagnostics. So yeah, so tropical infectious disease diagnostics, just to have a snapshot of what is available. In my left-hand side, this is a panel figure that we created a while ago for clinical microbiology reviews cover page, depicting diagnostics for systems. I'll be getting to that one a little while. And so we have these classical microscopy-based diagnostics, and then serology, antigen and antibody detection, and then of course clinical other diagnostics, and then nucleic acid detection. Under that we have all these molecular diagnostics, the modern day ones. And then not only the direct human or patient detection, but also the environmental, including vectors or reservoirs. So the value of diagnosis is not just the technological advancement or improvement, as I pointed out earlier as well. And this needs compatibility with testing environment. When we say testing environment, it's actually population characteristics. We need to think of socio-cultural applicability of these methods as well. Otherwise, definitely it's not going to be of practical use. And then prevalence of target disease, and comorbidities and co-infections, and health system characteristics. These are very, very important, that we need to learn from the community, society, or the specific regional interests before we plan and go ahead with applying or suggesting diagnostics. So yeah, I started looking at the diagnostic aspects, and then the depth and breadth of diagnostics for infectious diseases a little while ago. And then so this is the one I was actually showing. They were keen on this paper, and then they invited us to go for a cover page. So we designed it. So just trying to show how the entire life cycle of a certain parasite can be utilized to diagnose patients, as well as the environmental circumstance evaluation, and to make strategies towards prevention and control. I just don't want you all to read any of these things, just showing the columns, and one of the recent reviews, just trying to sum up the available diagnostics Right. So microscopy, serology, and molecular, and then this is just an example. Blood-borne protozoan infections here. I would like to take your attention towards proteomics here, MALDI-TOF, and then mass spectrometry-based proteomic approaches. I mean, those are not really direct patient management, patient support diagnostics. These are for understanding the disease, to learn more about the biology or the disease, and then to think of other strategies, probably maybe towards drug development, further diagnostic development. So those are the applications of those sort of tests. And now, as I said, I'm not going to go into deep technical details. I'm going to give an overview of where it looks like heading to. And so I'm taking two examples of possible modern developments in terms of biological applications. One is the cell-free DNA, where we have worked a bit on that. And then the other one is a potentially coming up thing. I mean, it's in use in oncology, mostly aptamers. I'm going to talk in the sense just to give you an introduction. Cell-free DNA as a diagnostic tool for, I mean, human parasitic infection. This was very interesting when I was trying to explore into this one. I noted that way before that, the concept of cell-free DNA diagnosis comes in early 2000s, but then even before that, people had explored and done a lot of work, analyzed clinical samples and published work, but not identifying that as cell-free DNA. That was very, very interesting. It's like, someone, some at certain point Everest was detected and then said this is the highest mountain. But then, of course, even before that, it was the highest mountain. Similarly, cell-free DNA was the concept, even though scientists had not recognized that as cell-free DNA, that has been in application. It's simply, we take a biological sample, biological specimen, could be, I'll go to this, urine or saliva, CSF, anything, and then, but for us to detect parasites or pathogens DNA, we really don't have to have the pathogen itself or itself in the clinical sample, biological specimen. It's with the pathogens turnover and with its excretory secretory products, it's highly likely and it's possible and it's happening. DNA, genetic material is anyway released to the surrounding environment, that is the bodily structures. And then when we get the sample, if we have the most accurate and the precise or sensitive diagnostics in place, we will be able to detect even the lowest copy numbers of pathogen DNA available. So it's, when it comes to the concept of cell-free DNA detection, we need to appreciate the fact that we are going to deal with something in low numbers, very low numbers, so that we need to have very sensitive techniques available to detect this. Say, for example, we are going for cell-free DNA in a systemic disease caused by pathogen, probably maybe malaria, so or schistosomiasis, or maybe I'm taking parasitological examples. Apologies for that. Or maybe visceral leishmaniasis. So, say for example, schistosomiasis or malaria, and then we need to test that. Considering a convenient sample, we are going for urine, not blood. If you take blood, it's obvious we can have. It's very clear if the patient is positive, we take a blood sample and then try to do DNA extraction. Obviously, we will be getting ample amount of DNA so that we can go for PCR analysis and confirm that. But for convenience, if we are going for a urine sample or saliva, then the chances of that parasite's DNA available in that sample is going to be much less because it's a different avenue that DNA has to be filtered onto those fluidic compartments, so that in that case, we need to make sure if we are designing a test for that, we need to have precise and most accurate tests available. Say, for example, not the conventional PCR would be able to detect that. We might need to go for even quantitative real-time PCR might not be able to detect that. So we might need to go for modern advances like droplet digital PCR. So where even a single copy would be detected on a given sample. So that's the way to sort of plan diagnostics towards high sensitive detection. Like this is what we actually did, trying to detect these ones with droplet digital PCR, some of the schistosomiasis ones, and then of course this helped us to identify so many pathogens and co-infections in certain communities. So just having a comparative look at towards prevention, control, and probable elimination or eradication of diseases. So just assume that we have conventional diagnostics in place. And then what happens is actually we have low diagnostic accuracy, conventional diagnostics, and then reduced disease detection. So at a certain level of prevalence, after a certain level of prevalence, this conventional low sensitive diagnostics would not be able to detect. That's lower the threshold. So what happens is we do the test in the community and then we detect this as negative. So for that particular test, disease is not existing in that community. So we have the assumption or the actually clear understanding that this disease is no more in this community. And then what happens is actually continuation of undetected disease in the community. So the eradication or elimination target cannot be achieved. It's just a false identification. So and then when you think of economic aspects as well, it's just continuing expenses in the long run. So that is very important to think about this expenditure as well, because sometimes when we think of investing on high tech and then investing on modern diagnostics, we might at the beginning might feel that yes, this is going to be very costly, it's useless to apply, but then in the long run, the case is going to be very different. And I'm taking cfDNA as an example. If you think of more accurate diagnostics, so then what happens is actually high establishment cost, obvious, but then early detection of cases, and then absolute detection of cases, and then effective treatment, better control and prevention. Disease prevention and elimination is achieved. So that's very important, something that we need to have in mind. And going beyond different PCR approaches, we have tested different serological testings as well towards coming into rapid detection. And I'm not going to discuss the results of these things. And in a nutshell, in summary, actually, these tests, all these modern molecular tests, or maybe the serological tests, all these have pros and cons depending on the context that we are looking at. That is what is exactly happening. So we would never say that this test is better than this test. It's all about the context. Where we are applying this, in which community, in which patient we are going to apply this. That is the what which determines whether a certain disease or certain diagnostic is good or bad in simplest terms. Yeah, so this is actually one of our ongoing work as a starting point. We are doing this district survey on intestinal parasitosis. And then, of course, there we are planning to apply novel modern techniques, simply explaining using conventional diagnostics. We say in certain diseases, certain areas, certain regions, we don't really have these infections. But then I have the previous experience that in such communities, such regions, when we go for a more precise diagnostics, obviously we see a big difference in terms of prevalence. So that we are just trying to apply this in the local setting and see how it works. And I just promised I will introduce this aptamer concept. So this is actually being used mostly for cancer detection. So this is basically potential application for DNA, RNA aptamers. These are like against proteins of different pathogens. So these aptamers are in vitro synthesized aptamers. These are nucleotide combinations. So these structures, like serological detection, they can bind unique different structures. Could be protein or anything. So that's the beauty of it. So when it comes to antigen antibody, we need to focus on proteins, protein to protein binding. But here it's a novel avenue which might sort of help us in future to expand diagnostics in a very wide way. We don't know much about its applicability in infectious diseases, but I just thought I should introduce this. Yeah, going a point further. As I said, I am focusing more on prevention and control, application of diagnostics for prevention and control. Yes, it's important that we think of point of care diagnostics. What is point of care diagnostics? Actually, it's a form of testing in which the analysis is performed where healthcare is provided close to or near the patient. So we try to do, in simple terms, we try to minimize time for diagnosis. Try to do the point of care, the diagnostics, then and there. So when we have that target, when we need to do that, when we are designing diagnostics, it's important for us to think of this time factor and then strategize accordingly. So just this figure, just depicting how much time we can actually save through point of care testing, and at the same time, it's very, very influential towards early detection and subsequently resulting from that prevention and control. So little more about point of care diagnostics. It's as I said, it needs to be, it's rapid testing, and it helps us better diagnosis, monitoring, and management of the patients. And rapid testing, obviously, the faster results. And since the procedurally final application is much simplified, digitalization is also can be incorporated into that, and then with that we can go for secure result storage and digitally to be accessed by healthcare providers, so that potential human time delays can be minimized with all these things. This concept, assured criteria for diagnostics, is not a very new concept. I think it's about 15 to 20 years old, but even for today, it's the gold standard concept people think of, or we need to think of, when we are thinking of or designing good diagnostics. So that needs to be affordable, obviously affordable. We need to think of the communities, the countries or regions where this test would be mostly applied. And if we develop a test or a diagnostic that can only be hosted or CDC Atlanta, but the disease is in Africa, West Africa, Central Africa, it's not affordable, not reachable. So no point having that, diagnostics of that caliber. So affordable, it needs to be sensitive and specific. That is all about the accuracy of these diagnostics, and has to be user friendly. If people, it's all about logistics and application at the end when it comes to community-based diagnostics, especially, and if it is not user friendly, I mean, as the way we have seen in the community setups and then public health, applications. If something is not going to be very user friendly, and if something is not going to be convenient, it's natural fate of that is, limited use and subsequent non-use. So it needs to be user friendly, and it needs to be rapid and robust. That makes it encouraging to use, and better equipment free. Say, for example, for a PCR to be done, we need, even for initial sample processing, DNA extraction, we need a lot of equipment. And then for thermocycling, we need the special costly equipment. And then if it is a conventional PCR, then again, we need we need to run the gel electrophoresis apparatus, and then we need the illuminator to see. So all bunch of instruments, equipment, so that is not going to reach all the needed places. Right? So yeah, it's again should be deliverable. Recently, there was so this is just showing how these assured criteria are applied in different diagnostic testings, and NATs, these nucleic acid amplification testing, and then antigen detection and antibody detection. So when you say like affordability, yes, NATs are least affordable because nucleic acid amplification test, commonly referred to PCR-based diagnostics, least affordable, very costly, and antigen detection and antibody detection. Antibody detection, obviously, the ELISA-based testing has been quite simplified, and it's now in doorstep with lateral flow assays, rapid use, and of course, results within half an hour kind of testing is available for many diseases now. Just an example. And then now we have this reassured criteria, slight advancement. This is a recent publication came in Nature Microbiology. So they have just given advanced step for reassured, that is real-time connectivity. Actually, when I look at that, what I feel is even within assured, there was this element embedded, but now they're trying to sort of highlight that point and take it out, like real-time connectivity. So we do the testing, and then it needs to reach, the results needs to be reached by all involved stakeholders, patient care, providers, and everybody, so that decision-making is faster, and the entire patient management process is made very efficient, or the community interventions are made efficient. And ease of specimen collection, that is the point that I made at the very beginning, and it's part of diagnostic criteria now, diagnostic principles. Yeah. So thinking of available diagnostics, different settings, the test availability could be highly variable. National specialist centers, NATs, all the serological testings and antibody antigen detection, as well as proteomic-based testings for further understanding of different diseases, so on. So when it comes to community health setups and the primary care, we we basically run efficiently with rapid diagnostic testing. So that's where we should be heading to, more as much as possible for these rapid diagnostic testings. Then only we can actually touch the base towards prevention and control strategies. And then when we think of these diagnostic tests, the balance between accuracy, affordability, and accessibility. I mean, the best would be to have, I mean, for me, what I feel is we should first think of accessibility and affordability. Without that, however much it is accurate, the practical use is going to be minimal, as I was emphasizing throughout this presentation. So, but then we need to be vigilant and updating on most accurate diagnostics or the novel developments that are available in different settings, so that we can think of at least to adopt those sort of things, not exactly as they are, but to a certain extent to our low resource settings. There are possibilities of doing, there would be a certain level of accuracy compromisation, but still it would be better than what we are actually practicing at the moment. Yes, I was just I'm just trying to link this to the my original slide previously. So yes, we are talking, we are in a journey starting from the initial clinical diagnosis, that is based on 5 senses, and then conventional diagnostics, and then for automation, where we are at the moment. And then the next, I would see that all relevant data being utilized, gathered, so with this reassured diagnostics, and then we are now trying to sort of identify risks and proactively target future disease causation. And obviously, the trend is we are trying to articulate all these things with modern AI concepts, artificial intelligence into that. There's a big contradicting understanding on this, and there are different schools of thought about incorporation of artificial intelligence into medical practice. Obviously, Elon Musk was last week warning everybody that we are running beyond the boundaries on artificial intelligence. But yes, we need to be vigilant on that. We need to try and think to find the balance. That is where the globe is heading, and we need to try and find this balance. So I was just trying to give you everything in a nutshell, in a broader view. This is not relevant to this, but I just wanted to give this. We are just after a big pandemic, and then of course throughout the pandemic we had this infodemic happening, and WHO had to make some intervention into that, so that they started the portal, infodemic management portal. This is an outcome of excessive knowledge. And when excessive knowledge is linked to uncontrolled social media use, it's going to be another disaster. So I'm just taking your attention to that, and I would like to thank you, everyone. And it's, as I was introducing, this is my home, and it's a pleasure to be back then and now. Thank you.
Yeah, thank you very much, Kosala, for a very informative talk. One of the difficult subject to deal with it, because being clinicians, diagnostics is something very confusing for us. I also welcome our Dean, Professor Vasantha Pintu, for this lecture. I mean, I'm sure that Kosala would like to answer a few questions coming from the audience. I'll start ball rolling from the chair, right? Right. As Kosala showed in the last slide, actually, there's about COVID. During COVID pandemic, we saw so many diagnostics are coming. All these parts of point of care diagnostic, like rapid diagnostic test, all those things are coming and how they were available. So that was a very best example how for a new disease, diagnostics came. So we learned so many new terms. Kosala mentioned cell-free DNA. Do you use that technique in the world for diagnosis nowadays?
Yes, like the publications that I showed, those were some recent applications actually. But then whether how much that is used in day-to-day patient management would be very, very restricted or limited to resource availability. So that's the point that we were actually discussing about trying to have this balance. We have this, for us to detect cell-free DNA, we need to have, depending on the sample, if we are trying to detect that in a, low available sample, then of course we need high tech. But then it's just a cell-free DNA detection is a concept. Simple, simply we are trying to detect DNA fragments without the existence of certain pathogen. So then, even say, for example, apologies, I'm taking a parasitological example for stool sample. We cannot detect microscope. Say, for example, a patient is infected, having a certain helminth infection, but then intensity is low, so that we cannot detect that in with microscopy diagnostics. But then we take the stool sample and try to extract DNA, which is of abundance with human DNA, but within that there could be parasite DNA in it. So we might not be actually fractioning a parasitic stage in that DNA extraction process, but we will be straight away capturing some DNA from the parasite. So that is unknowingly we might be applying this cfDNA concept, sir. But then if you are obvious about like the example I used for malaria, like if you are thinking of a convenient sample, going for saliva, urine, we know that the potential availability of pathogen DNA is much less. There, of course, we need to, the applicability would be limited unless we have the resources.
Yeah, I remember, Kosal, actually, maybe somewhere around 2009, I took part in one study on diagnosis of dengue from saliva. So more than actually taking a blood sample, to take a saliva sample. So we did it, but I don't know what has happened to the outcome, right? So it was just a research we did in collaboration in Singapore. Any more questions? Yeah.
So this will be a very simple question related to the antigens and antibodies. So when we are dealing with infectious diseases, there are certain times that we may have to rely on antibodies and antigen testing, because most of the time we are not fortunate to get the cultures. So as an example, melioidosis. So the cultures we are waiting, but we are not success. May not be happy. So if this antibody testing comes as very low titers, are we to believe the patient is having this disease, or what sort of
Yes.
conclusions that you can give?
Great. I think that would be one of the most difficult questions to answer. And then, of course, the other thing is it's context specific decisions we might have to take. Say, for example, now the question asked like about this antibody titer would be much lower, and then whether we are to come to a diagnosis based on that low antibody titer. If you try to fraction that a bit more, my maybe something related to me. So if you try to think of IgM and IgG in simple understanding. For rickettsial infections, as Sir would explain better than me, IgM tend to last for yes, tend to last longer. But then usual understanding is IgM should go down in a shorter period. But that's what I said, like it would be very context specific thing. So apologies, I'm not very specific about melioidosis situation. Maybe from the audience we can get a better answer.
I think probably an value has been established. I'm not very sure I can change, but if a cutoff is established, then based on that, you can cutoff value. But I'm going to is my worry because so yes, so because recently we had that problem in the ward, isn't it, Buddhika? So because I'm wondering why do we have the national cutoff? Because if somebody is positive for, I mean, antibodies are positive, and are we to treat and wait to get the 2 weeks antibody testing just to see whether the patient is having a rising titer, or whether just to disregard that value because it is below the national cutoff? I think that again, just like the radiologists say, correlate clinically. If your clinical judgment is very high, even if it's a lower antibody titer, you treat it. Yeah. Then I guess you go with the clinical judgment and then actually go for the convalescent sample. Then testing both will actually give you the confirmation. And if you build sufficient data in that context to show that even with an initial lower titer, this is being confirmed, then that is a good premise to ask for a revisal for the national cutoff. So I guess that is probably a way to approach that. Sorry, Kosala.
That's so good. Thank you for taking the challenge. Yes, madam.
Thank you. Even though I joined late, thank you very much, Kosala. It's a very innovative thinking and new knowledge for us. Just a question, as a clinician, I'm asking this question because most of the time we are running short of time to treat a patient. So most of the time we go for a tentative diagnosis and empirical treatment. So do we have, I know that you were talking about a bit of a more hyper stuff, but do we have a database in our country of each disease, the minimum diagnostic time? Do we have something like that for our clinicians to, just like your cutoffs, the time is also important for us, especially when it is a life-threatening. So I'm not sure whether do we have that. Don't you think that we should have that?
Yes,
it
actually.
Could be an eye-opener.
True, madam. And then I think, rather than a question, it's a, thought that you are trying to establish. I think that's really, really important. And not a timely, but, delayed intervention. So we should do that.
Yeah.
Yeah. I mean,
yes, true. Yeah.
Yes, sir.
Yeah, so I think that should be, we should have a young workforce behind this. I would say young because you have a long time to work on this. I think you young people who are so armored with the knowledge should take some initiative on this matter. I think Buddhika, I don't know. Some you all might give you some of your thoughts, isn't it, sir?
Yes.
So we don't at the moment. I don't know because for how long I had to wait for that, and in what context, in which hospital, and which type of stage I need to wait for that, and things like that. Thank you.
Exactly. And
any more questions from this young audience? Okay, in the absence of more questions, as Professor Vasantapintu said, I mean, it's a kind of communication between the clinician and the laboratory, right? Laboratory. The clinician is in challenge to save the patient's life, right? So lab need to provide the backup. So the
Yes.
diagnostics and how fast you are going to give these diagnostic results and accuracy, all those things are very important. That's actually these type of lectures, we are trying to go beyond our clinical limits to understand the world trend nowadays. So that's the very reason actually I invited Kosala to come and talk about the diagnostics, because being clinicians, we are not very much familiar with that field. So thank you very much, Kosala, coming from Anuradhapura to do this presentation. And these CRTM lectures will be available in our website for future. So it's investment, right?
Yes.
So that's it. Yes.
Right.
Yes.
And to be on the website.
Yes.
We are going to have a bit of more publicity in this as well.
Yes.
Great. I think that's a really nice initiative, and then it's going to be very, very helpful for the entire country itself, because it's going to be, good talks to come in as well. And madam, just to add to your thought, I think the starting point should be at least to
You can,
at least to have a catalog of reference centers. Rather than the TLS, because whenever we want to, sometimes we get questions like, can this be done? Can this be done? Or where, sometimes in the ward we might come across the problem like where to send this sample, where to get this done, and we struggle a lot on that. So at least that would be the starting point. Yeah. Sure, madam.
Yeah.
Yes, madam.
We don't
Yeah.
know.
Yes.
We don't know where the relay stations are. We don't know the time lapses in each.
Yes.
And rather than asking from the hierarchy to give us this, that, and all, we should provide the data, sir.
Yes.
And that's where we are looking.
Yeah.
There are so many young blood here who can carry this in a way of a research or something forward. I believe.
Great.
Thank you very much, Kosala, visiting your.
Thank you, madam, and thank you, sir, and the entire audience for inviting me and then providing me an opportunity to share my thoughts. Thanks.
An extended invitation for you to visit the flowers. What is the word you use? Golden?
That's close.
No, he used a beautiful word for that. Golden something. Yeah, please.
Yes.
Okay. Thank you very much, Kosala. So next lecture will be in 1 month's time.
Great.
Thank you, sir.